Good afternoon. I'm Dr. Cynthia Stunkel, and here with Dr. John Stevenson for the Meet the Professor, talking about use of hormone therapy in a cardiovascular, safe and beneficial way. We've prepared a few cases to go through, but we really are open to your comments and questions, so please feel free to stand up, raise your hand. There are some microphones that would help the other colleagues in the room to hear. And with that, I think we'll begin.
So what I'm going to do is to present a case to you, which hopefully will illustrate some interesting points. And if there's anything that you want to know or that I haven't said properly, or you can't understand my accent, just let me know as we go along. So this is a 52-year-old female who has had amenorrhea for 9 months, for the past 9 months, and she's suffering from night sweats and from irritability. And of relevance, she also gets a feeling of lightheadedness and sudden fatigue and feels a bit shaky mid-morning. And those are quite important symptoms as far as I'm concerned. Particularly the sudden fatigue is often an indication that she may have insulin resistance. And patients often describe it like they feel like somebody's pulled a plug out on them. And she's now got central chest tightness on exertion. She's had carbohydrate cravings for quite a long time and has gained weight over many years. And of relevance, there is a family history of coronary disease in her mother. Her mother had a heart attack at the age of 62, so that was pretty early on. Okay, so I'm going to show the examination. So she's got a BMI of 32, so she's obese. She's got an increased waist circumference of 92 centimeters. I've put the normal there in case you're more used to dealing in inches rather than centimeters. And her blood pressure was 150/90. And the ideal really would be 120/80 or even below. So that's the case that we've got confronting us, and we'll do some investigations. Has anybody got anything that you particularly like to do in the way of investigations? Yeah. But if you want, yes.
Yeah, cardiac first.
You want cardiac first?
Well, because that chest pain concerns me, especially with her family history.
Yeah, yeah. Okay. So what we did was an MRI perfusion scan. Are you happy with that? Is that okay?
Well, we wouldn't have access to that immediately.
Right.
I would think that would take too long to organize, but let's say you have the money for it.
Well, I work at a heart hospital, and there's all these incredibly wealthy cardiologists there, you know. Have you ever met a poor cardiologist? So what we did was we did a fasting lipid profile as well, fasting glucose and fasting insulin, thinking of the possibility of insulin resistance. So if I show you the blood workout first, and then we'll show the MRI scan. So this is what we've got in terms of her lipid profile. So she's got an elevated LDL cholesterol. I've put the normal values there in case you're used to dealing in milligrams per deciliter. These are all millimoles. So she's got an elevated LDL cholesterol. She's got a slightly low HDL cholesterol, and she's got clearly elevated triglycerides. So that's clearly an abnormal lipid pattern. So there are various things we could do about that, but obviously, since she's got menopausal symptoms, if we're thinking of HRT, then we'd need to choose an HRT that could actually try and tackle the abnormalities that we've got here. If I just remind you of what HRT will do, so it's going to lower her LDL cholesterol, which is what we want. It could either increase her HDL cholesterol or we could try and lower her triglycerides depending on which hormones we choose and the routes of administration. So I showed that slide earlier today. And then looking at the glucose and insulin side of things, where are we? Here we are. So she's got a normal fasting glucose and a normal fasting insulin, but when you put do the HOMA calculation, she's actually got evidence of insulin resistance. So the normal HOMA would be less than 2.25, and hers works out at 2.6. So we can say that she has got insulin resistance. And again, thinking of what we can do about that, and thinking of hormone replacement therapy, we can tailor the hormones to see if we can improve her insulin resistance. So just to remind you that oral estradiol 17-beta will improve insulin resistance. If we gave a low-dose conjugated equine estrogens, that probably wouldn't do very much at all. Transdermal estradiol may have a small effect on improving insulin resistance, but we'd have to watch out for what sort of progestogen we would give, because the androgenic progestogens, including medroxyprogesterone acetate, will actually make insulin resistance worse. If you give them transdermally, however, if you give the transdermal norethistron, that's not going to have any negative effect on the insulin resistance. So, but we could give her an oral non-androgenic progestogen, and then you'd still get the benefit from the estrogen in terms of her insulin resistance. And this is the result of the expensive MRI scan. And basically it showed subendocardial hypoperfusion, which is the MRI hallmark, really, of microvascular angina. What we find is that when you inject the adenosine doing this scan, that if it reproduces their chest pain, then that seems to be a really good indication that they've got microvascular angina. And you know, even if you don't see the hypoperfusion, if they get the pain when you inject the adenosine, then that usually means that they have got microvascular angina. But sometimes the MRI scan is just not sensitive enough to be able to pick it up in every case. Okay, so if we look now, so we've got evidence of microvascular angina, which would explain her chest pain, and we've got the lipid and glucose abnormalities, and her physical measurements as well. So she's actually got the criteria for a diagnosis of metabolic syndrome. And just to remind you that the criteria for diagnosing metabolic syndrome is any three of the following that are shown there. So an increased waist circumference, a fasting glucose above 5.6, or if the patient is on any form of glucose-lowering therapy, an HDL cholesterol of below 1.3, fasting triglycerides above 1.7, and a blood pressure systolic above 130 or a diastolic above 85. So any three of those would actually, those criteria would actually make the diagnosis of metabolic syndrome. And you note, of course, that they do have, for the waist circumference, we do have sort of one set of measurements for the USA and then another set of measurements for the rest of the world. I don't need to comment further. So the diagnosis then is metabolic syndrome and microvascular angina. So what should we do? Any suggestions as to any sort of treatment we could give? Well, it's a menopause conference, so we've got to talk about HRT.
You don't think that first you have to treat her blood pressure and secondary insulin resistance with metformin and see what happens?
Well, yeah, it's a good point, Anne. But I think that we could actually start to treat all of those things with HRT, because we could probably lower her blood pressure a little bit.
Treating a woman with a high blood pressure and microvascular angina and not stable, I will not do that with HRT. I will first control her cardiovascular risk factors.
Well, I think you can do it with HRT. And in fact, that's exactly what we did in this case. So I actually started her on oral estradiol 17 beta because she only had 9 months of amenorrhea, and so we've given her a cyclical progestogen, cyclical dihydrogesterone. Important to alter her diet. For people with insulin resistance, certainly in the UK, we use a low glycemic index diet, which I think is very important. And we also make sure that she always has a bit of protein with every meal. And I tell the patients that, you know, the protein is like giving a slow-release sugar, so that you're getting a trickle of sugar going into the bloodstream rather than a surge, but it stops them from getting hungry, because the last thing I wanted for someone like her is to be eating snacks between meals. So 3 meals a day, and no snacks, and low GI foods, so that you're giving her a chance. And the idea of the low GI diet, again, is it's to stop surges of glucose in the blood, because if you're going to get any simple carbohydrates, they get so rapidly absorbed, you get a quick spike of sugar in the blood, stimulates the pancreas, and if you keep stimulating the pancreas, it's putting out additional insulin anyhow, because she's insulin resistant, and the more insulin she puts out, then you get more downregulation of the insulin receptors, and so you just get into a vicious circle or a vicious spiral of increasing insulin resistance, which will increase her central weight gain, which will increase her insulin resistance even further, and so on. So the diet is a very important part of the management. So that's what we did. Let's see what happens. So 6 months later, this is the situation. She's actually lost 6 kilograms in weight, which makes her quite a unique patient. Usually when you tell a patient to lose weight, they gain it. The night sweats have resolved with the HRT, her irritability is resolved, and the chest tightness has also resolved. And this is due to the fact that the estradiol will be having a direct vascular effect, improving her vascular health. But she's still got her mid-morning symptoms of getting fatigue and shakiness mid-morning. And that's probably due to the fact that because she's got insulin resistance, she's hyperinsulinemic, and therefore what happens is that they drop the blood sugar, but within the normal range. They don't go hypoglycemic, but because there's so much insulin around, they drop the blood sugar in the normal range, but the rate of fall is quite rapid, and that triggers the symptoms of hypoglycemia, and that's where her mid-morning fatigue and shakiness is coming from. So we did some more investigations now that she's lost a bit of weight.
Do you want to take the questions?
Oh, yeah.
I would be worried that they criticise about giving oral estrogen in case you trigger some event because of clotting.
Okay. Well, why would you be worrying about triggering some event? I mean, she's not got atheromatous heart disease. She's got microvascular angina.
I didn't understand the difference between those things, being a gynecologist.
Oh, okay. Well, basically, the microvascular angina we think it's just a dysfunction of the microcirculation in the myocardium. So in the main epicardial coronaries, you don't have any blockage or anything like that, and it's just small vessel dysfunction that causes the angina, and symptomatically, it often responds very well to HRT in postmenopausal women. I mean, we do get microvascular angina in men, and we don't treat them with estrogen. Well, at least as far as I know, we don't. But it certainly, about probably 50 to 60% of women, postmenopausal women with microvascular angina, will show a symptomatic improvement to the estrogen. And in this case, she actually did, which was good.
The problem of the oral estrogen is also that it's increased triglyceride, whereas the transdermal estradiol decreased triglyceride. That was shown by Jarvis in the antiquity. But so I would not promote oral estradiol. Second point, you said that transdermal estradiol.
And please use the microphone because I'm an old man. I cannot hear you.
I know. Welcome to the club. So, well, the second point in the E3 and cohort study from Françoise Clavel, she showed that estradiol, whether oral or transdermal, combined with progesterone, was the most efficient treatment. It's not randomized, of course, it's observational, to decrease the prevalence of diabetes type 2. So it's difficult to understand what you said about transdermal estradiol. At least combined with progesterone, it has the same preventive effect against diabetes type 2.
Okay. Well, here, yeah, I mean, that is the problem, that we're hoping that she's going to improve her insulin resistance with the oral estradiol, and then hoping that she's going to increase her HDL cholesterol, but also hoping that she doesn't elevate her triglycerides any further. Now, the fact that she's on the diet and that she's achieving weight loss may well help to normalize her or improve her triglycerides anyhow, despite the oral estradiol. So let me show you. This is what she looks like now. So her BMI has actually fallen, so she's now overweight but not obese. Her waist circumference has improved, but it's still excessive. Her blood pressure has stayed pretty much the same, but her HDL cholesterol has improved. Her LDL cholesterol is almost normal, but her triglycerides are still elevated, and the HOMA index has also normalized as well. So the question then is, what should we do next? Yeah.
How much of that is just due to weight loss alone? And then how do we know how much of it is due to the estrogen and how much of it is the weight loss?
No way, to my knowledge, there's no way of telling. Absolutely no way of telling. But she needs the estrogen to get rid of her menopausal symptoms, you know, irrespective of the metabolic effects of it. And, of course, it's got rid of her angina. So the question is then, what should we do next?
Transdermal estrogen is better for dropping triglycerides?
Yes. Yes, it is. If you give estradiol transdermally, you actually it will lower triglycerides rather than raise them. So that's the difference in the routes of administration between the oral and transdermal. Is on the triglycerides. But you'll have less of an effect from transdermal on the insulin resistance. I mean, it may improve it a little bit, but you won't get as big an effect, and you'll have less effect in terms of lowering the LDL and raising the HDL. So, you know, it's very much swings and roundabouts, and you guess and try it and see what happens.
John, in this woman, in the follow-up, we would rather change the progestin, like I'm talking about the possibility to use an anti-aldosteronic progestin in order to try to decrease the blood pressure rate.
Yeah, I mean, you could do so using drospirenone.
Yeah.
That was a possibility, but certainly in the UK, we only have drospirenone available as a continuous combined estrogen-progestogen. And really, I didn't want to give her, I wanted her to have a sequential one because she's still, you know, even perimenopausal. She's not fully menopausal.
If she was 53, 2 years after menopause, what kind of a combination would you recommend?
Well, you could use estradiol and drospirenone if she was 2 years into the menopause. That would certainly be a possibility. Although we don't tend to use, I mean, I don't know if you use it a lot in Italy, but we don't tend to use it a great deal in the UK for no good reason. Okay, so we've still got a problem with her. She's still overweight, and she's still getting the symptoms of hypoglycemia, even though she's not got true hypoglycemia. So what we decided to do was to actually put her on Metformin. And so I thought that, well, that's going to help her weight, that's going to help her triglycerides and everything else. So we started her on slow-release Metformin, start on 500 milligrams a day, and then after 2 weeks increased it to 1,000 milligrams, and then after another 2 weeks, to 1,500 milligrams, and that's the sort of standard dose that we would use to treat insulin resistance per se, without it being actual diabetes. She'd continue on the diet, we'd continue her on the HRT, and 6 months later, she's lost a further 6 kilograms in weight. I mean, this is all becoming a bit unreal, isn't it? She feels...
After 60 years, she can continue HRT?
Sorry?
After she's 60 years old.
Oh, well, as far as I'm concerned, after she's age 60, if she wants to continue on HRT, yes, she certainly can, but she's not. She's only 53. So she's got a good number of years to go yet before she gets to that age. So she feels very well, got more energy, and now the mid-morning symptoms have resolved, and that was almost certainly the effect of the metformin as well as the weight loss. So this is what she looks like now. So she's nearly normalized her body mass index, she's nearly normalized her waist circumference, and her blood pressure has actually improved, and that is almost certainly going to be the weight loss rather than anything else that's improving her blood pressure. Are you happy with that blood pressure now, Anne?
I would be happy, but certain others would not.
Yeah, okay.
Still, I am not sure I have put her as a first line on HRT, these women. Definitely, but try other means to alleviate her symptoms.
What other means would you try?
So the non-hormonal alternative, maybe progesterone alone. In some instances, it can help to alleviate hot flushes. And non-hormonal means, I mean SSRI and so on. I will explain her that if she lost weight, if we control her insulin resistance, then her hot flushes will decrease. We had an oral communication one day ago showing that in atypical hot flushes, half of the patients have insulin resistance. So definitely controlling the insulin resistance could help to control the hot flushes at some instance at least. So that what I would have proposed to this patient.
Would it help her mood, though? Would it help her mood? She had irritability.
Okay, but if she exercise, I think exercise is very important for the mood, for sleep, and so on. So, and cognitive, therapeutic, and things like that. But of course, maybe I should give her a transdermal HRT combined with progesterone, of course, as a second or third line, but not the first line. And after controlling all the risk factors and the blood pressure first, because the risk of stroke with oral estradiol in a woman with insulin resistance and high blood pressure, for me, it's absolutely a contraindication.
Would you use the microphone, please? Please step to the microphone. Thank you.
I don't understand why you want to delay the start of the HRT. You're afraid of what?
Stroke. I mean, she has the high blood pressure and insulin resistance. She's at risk of stroke.
Yes, but
I don't think her risk of stroke is very high at all.
if you come,
She has I mean, I wouldn't call that high blood pressure. But it's not high. I mean, it's slightly raised.
We're learning that everything is relative. Yeah.
Absolutely.
because if she feels better quickly with the hot flashes, she will have the energy to lose weight, to sleep, to, voilà. But I will add immediately Metformin since the beginning.
You'd have put her on metformin from the beginning?
Wait, Metformin.
Yeah, well, that's certainly a possibility as well. I didn't talk about exercise and whatnot because in the UK, the people don't tend to exercise. Yeah, well, no, the only exercise we take on it is sort of leaving the European Union. So if we go on to look at what her her latest
John,
met-
there's another question.
metabolic, yeah.
Sorry for my English. I'm from Chile,
That's okay.
and I'm still worried about. You know that oral has a first hepatic pass.
Yeah.
So you with oral, you stimulate procoagulant factors. So that's the. I think that is what we are talking about when we say that woman, this woman in this case, has a risk of stroke, and you are given oral that would increase her risk because of procoagulant factors that are stimulating with estrogen, oral estrogen.
But I still think that her risk of stroke is very, very low. And by improving her insulin resistance and getting her to lose weight, you're going to be reducing that tiny, tiny risk that she's got anyhow. So it's all a case of balance, isn't it? You know, you risk something to improve something else. So if you look at her follow-up figures now, so now her LDL cholesterol is completely normal, and that's been helped obviously by the weight. Her triglycerides have now normalized. Her insulin resistance index is further improved, and her HDL has come up a bit further as well. So we've metabolically fairly normalized her. And so my last sort of slide on this is what do we do next? I mean, she's on HRT, she's on Metformin. Should we leave her on it? Should we change anything? Okay, well, this is what we did. We actually just said, no, stay on the HRT because she's feeling very well on it. And the plan would be to change her to a continuous combined estrogen-progestogen regimen after a couple of years. That should be okay. To continue on the diet. In terms of the metformin, I mean, there is no evidence base that I can use to tell me what to do with the metformin. So we're back to my favorite, you know, the prejudice-based medicine. And what I thought was just leave her on the metformin until her BMI and her waist circumference are completely normal, and then just try gradually reducing the metformin and see what happens to her metabolic parameters. So that would be the idea of what we'd do. No, I wouldn't, because she's got a normal lipid profile with the HRT, so I wouldn't put her on a statin as well. Yes? At what point would I consider weaning?
I mean, how much time has gone by, John, between when you started and when you got her to this point?
This is just over 2 years.
2 years.
Yeah. So I wouldn't, I mean, that would be up to her. If she says, oh, I want to come off the HRT, then my advice to her would be, well, come off it very slowly. Because although we know from Tommy Mickler's data that you've got an increased risk of heart attack and stroke when you stop HRT, but I suspect that would be if you stopped it abruptly, and that would make biological sense to actually just reduce it very gradually. But I mean, that's if she wanted to come off the HRT. I wouldn't encourage her to come off HRT. I would tell her to stay on the HRT until she gets a telegram from the Queen.
Would you reduce the dose, John?
Not necessarily. I mean, you know, some people say, well, as you get older, it's probably wise to actually lower the dose a bit. But, you know, we've no evidence for that at all. Certainly what we'd do is, when you're weaning people off, you just drop the dose a little bit and wait for a couple of months. And if they feel all right, you drop it a bit further. But if they then start getting some symptoms back, then we put it back to the dose where she didn't have symptoms. And that's the way that I would manage her. Incidentally, for those of you that don't know, in the UK, if you reach the age of 100, you get a telegram from the Queen. So that's the idea of waiting for the telegram. And though, for her, of course, it won't be the Queen, it'll be the King. Yes?
Am I correct in understanding that your reason for using oral estrogen is despite the
sex hormone binding globulin and decreasing circulating, available circulating androgens, which would benefit the inflammatory condition. That wouldn't be my reason for using the oral estrogen, though. I mean, the main reason for going for the oral estradiol is purely because that has the best effect on insulin sensitivity. And that was my reason for choosing that specifically, oral rather than transdermal.
Yeah. Some women find that the decline in free testosterone when their sex hormone binding globulin is increased with oral estrogen therapy can have some sexual effects as well. So in general, I think it's good to be mindful that you will be lowering free testosterone, and that may not be a desired outcome in all women.
So, yes.
Which product, John?
The, oh yeah, that's estetrol. It's
Oh,
but it's not available.
I don't know anything about it.
Oh, I don't know. I'd have to sit down and have a long think about that one. But basically, yes.
I just wanted to ask, in women who have a previous history of PCOS in their reproductive life, given that they may have insulin resistance, would you recommend they have oral estrogens for MHT rather than transdermal? I speak as someone working in the UK who would naturally prescribe transdermal estrogens for MHT.
It would depend on whether they'd actually got true evidence of insulin resistance. I mean, if they'd had PCOS, you could say, oh, well, they could have been insulin resistant at one time, they may not be now. And so I wouldn't just automatically say, oh, I must just give them transdermal. So we've got an audience here of gynecologists, and you've just been treating a heart patient. So that should make you feel good. You see, it's
May I have a question?
quite easy to do. Yeah.
Another provocative question. This patient come to you consultation, and she doesn't have any symptoms of the menopause.
She did have symptoms of the menopause.
No, but she's not having any symptoms. What are you?
Oh, I see. An asymptomatic woman.
Yes.
I would probably treat her much the same way. And just in case, you see, just in case any of you sort of would be nervous about treating heart conditions as gynecologists, I think you're perfectly justified in doing so. I'll show you my last slide, which is the gynecologist's view of the heart. A uterus-shaped organ situated in the chest whose primary function is to pump blood to the ovaries.